Um, so welcome everyone to Family Medicine Grand Rounds. Today's December 2nd, 2020. And of course, our event ID is 337047. You can join in a multitude of ways, so we look forward to having you join us. Next slide. We always like to thank people for, of course, muting their microphones once the presentation starts, being attentive to the presenter, and of course, engaged as well. And then at the end, please complete and submit your session evaluation. These are important not only to Dr. Berggren, but as well to our grand rounds in general. Next slide. We, of course, present grand rounds with our educational partner, who is South Central AHEC. So thank you for their continued support. Next slide. And then, of course, for CME transcripts, you can directly reach out to CME to get any transcripts or have any questions answered as well. They're very friendly and very responsive, so please feel free to contact them. Next slide. And then we also, of course, have AAFP credit, so please feel free to reach out to Nicole if you have any questions about AAFP credit. Next slide. Dr. Berggren has no relevant financial interest with commercial interest to disclose. So having said that, next slide. It is a pleasure for me to introduce Dr. Ruth Berggren. She is a professor of medicine within the Division of Infectious Disease, and she is also the director for the Center for Medical Humanities and Ethics here at UT Health San Antonio. She will be presenting today, Racism and Discrimination in Healthcare and the Clinical Learning Environment, a Call to Action. Thank you, Dr. Berggren, and I'll give you the floor.
Thank you so much. I really appreciate the privilege of being able to present to your group today. And I thank you so much for the questions that you submitted in advance, which I've embedded. This is a work in progress, and I have been privileged to deliver this presentation to several other departments. And it is my goal to get around to as many departments in our School of Medicine as will have me, and that each time I present, it reflects something new and something that I've learned and something, a way of improving or making the message more graspable, more important, and more salient. So you've already contributed to that, and I hope you will afterwards as well. So these are my formal learning objectives. My next slide will be some informal learning objectives and breaking it down a little bit, but we're going to examine how historical and social practices like redlining and jailing give rise to health inequities, adverse health outcomes like diabetes and its related complications, as well as susceptibility to pandemic disease, something I'm keenly attuned to since I'm here talking to you today while I'm on the COVID service, just finishing up the home stretch of a week of COVID consults. We'll identify potential approaches to improve health outcomes and care within current contextual challenges to our US healthcare system. And I wanna stress that we're gonna talk about current contextual challenges in our own community as well. And then if time permits, after I get through all the questions from family medicine, I'll go over 6 steps that individuals can employ to speak up and mitigate racist behavior in the healthcare environment. And my informal objectives, trying to unpack this is I want to address right up front, why is this so difficult to talk about? And it has been difficult, especially on Zoom. I sometimes don't know how people are responding to me, and it's been difficult since before the pandemic and before we were doing Zoom. I had a difficult conversation with somebody who is a community supporter of the Center for Medical Humanities and Ethics who didn't understand why we were focusing on very explicit racism in healthcare when we were inviting Dr. Damon Tweedy to come and give our Frank Bryant lecture. And this person felt a little offended, a little put out with me and said, we're past all that. And it's been a process to try to come together and say that, no, we're not past it. And here's the evidence. And why does this make us so uncomfortable? So I'm going to talk about and define this term white fragility, which is one of our big obstacles that makes it hard to talk about. And then we'll go into how did we get here and why does it matter, and a sampling of history. And I realize there are many experts in this audience. However, I think it is worthwhile and valid to review some of the key historical facts that have brought us to where we are today. And it reminds us that we're not individually culpable for all that transpired centuries ago, but without that context, we can't really understand what we're dealing with. And in particular, I want to emphasize redlining. Most of what I've learned about redlining, I learned from family and community medicine, Dr. Ferrer. But when I go and speak to internal medicine residents and I ask them to raise their hand if they know what redlining is, very, very few can raise their hands. So I will share some highlights of the Tuskegee experiment, which I know you're familiar with, but reviewing it for me was enlightening. We'll talk a little bit about Henrietta Lacks and what we've learned through her story. And then really, I think it's important that we land on what we can do, not only as individuals, but on the systemic level, departmental level, and the personal level. And within that will be the questions from your department. And I really love this quote from Martin Luther King to frame this presentation, that of all the forms of inequality, injustice in health and healthcare is the most shocking and inhumane. So you did hear that I'm the director of the Center for Medical Humanities and Ethics. This is our mission statement. We are preparing tomorrow's healers to act with compassion and justice. We like to envision our center very much like this tree as a sheltering place for all that is human about us and for humanity. Many of the slides in my presentation, especially the ones that are historical and text heavy, I borrowed from my colleague, Dr. Wari Allison, who is an assistant professor of medicine and infectious diseases, and this is very intentional. These were slides that she was to present at a grand rounds for internal medicine that got interrupted in July, and I'll tell you a little bit about that. The other disclosure about myself on this slide, I think is really important that I am honest about where I come from. I grew up in rural Haiti. With parents who were public health professionals. And I grew up as a white, blonde-haired child in a very poor environment where people were Black. And I was somebody who stuck out like a sore thumb, but I was somebody who was very privileged. And throughout my life, I believed, well, with that kind of background, I couldn't possibly have implicit bias or racial bias. But my disclosure to you is that as a 2-year-old, I had learned how to walk and talk in Congo, and I knew to speak Lingala and was learning in English as well. And when my parents came back to the United States and we were in an airport as a 2-year-old, I ran up to people of color and would speak to them in Lingala. And I would go to people who were white and I would speak to them in English, because that is how my developing brain had come to understand the world and the way things are. And as I have continued on the journey of trying to understand how my early experiences shaped my perception of reality, I have to disclose that as a child growing up in Haiti, I had a diverse group of people around me, but it is true that the people who were serving, people who were household servants, were Haitian Black people, and the people who were leading and providing medical care were of mixed races, but a predominance of people who were white. And this was another developmental aspect of understanding my world, and then realizing how these things become part of my unconscious, and then I have to think hard about how does that affect me today. I wanted to get more local historical context to what we're talking about today. So May 25th, that's the day that George Floyd was asphyxiated. On June 7th, our organization, our institution, gathered together with the University of Incarnate Word and held a demonstration called White Coats for Black Lives. On June 11th, the Center for Medical Humanities and Ethics hosted an online webinar that is archived at panpals.org. I am advertising that to you. I invite you to go take a look at it. It was called Critical Discussion on the Racial Divide, and we brought together faith leaders of different races and different faiths together on the web to have a discussion in the wake of the George Floyd incident and the White Coats for Black Lives and the Black Lives Matter demonstrations. Later that month, we also held a webinar, also archived, you can still go to it, called Why Are We Dying? Race, Ethnicity, and Health Justice in the COVID-19 Era. And on July 22nd, Dr. Allison's medical grand rounds, which was titled Health Inequities During a Pandemic, where we've been, where we are, and where we must go was actually Zoom bombed. So somebody took over the screen as we were about halfway through, and we were bombarded with images of Nazi Germany, of bombs going off, and horrible voiceover with explicit language that was derogatory and demeaning. It was a degrading experience for all of us. And of course, we've had to step up security. But to say that we are past the era of racism being an issue and that it's not an issue in the healthcare academic environment is to ignore these things that have been going on very recently. And then finally, just this past month, a white supremacist group distributed white supremacist literature and flyers on San Antonio's north side. So this is affecting us on many levels, and it is all around us. This is just another preview of that panel discussion on PALS, that stands for Pandemic Pals. It's a website that my colleague, Dr. Rachel Pearson, has developed and curated that is under our umbrella at the center, but which is intended to help all of us retain our humanity during this terrible time of pandemic. Now, before I continue, I want to share with you a lesson that I've learned from this woman, Janice Dunbar Travis. I found this quote of hers in a blog that she had written, and I thought it was helpful and validating for what it is that I'm trying to do. And in her blog, she says, so often white people seem to be waiting for Black people to share our life experiences and frustrations while they silently sit and add nothing to discussions. Too often Black people are looked at as the ones who should come up with the solutions. This country's problem of inequity was not created by Black people and cannot be solved by Black people alone. Hearing the stories of white Americans' experience of race would be helpful and give greater understanding about who we all are and our collective path that led us to this place. So Janice Dunbar Travis works for the MacArthur Foundation. I told you at the beginning that I would define and unpack this term white fragility, which I think is the big elephant in the room, what makes it hard to talk about, what makes people feel awkward. And I haven't yet read Robin DiAngelo's book, which I've depicted here, but I have listened to her webinars and online presentations and interviews enough to have grasped this concept. She defines white fragility as she's a social scientist basically, and she describes this as the discomfort and the defensiveness on the part of a white person when confronted by information about racial inequality and injustice. And she is a fairly provocative writer who pushes us to think harder and deeper and maybe to go into places that we naturally want to avoid. And she says things like nice white people who really aren't doing anything other than being nice people are racist. We are complicit with that system. There is no neutral place. Well, that was affronting to me when I read it, but it did cause me to reflect on an incident that I can share with you about something that happened when I was in college. Racist systems aren't something that people necessarily opt into. I didn't choose my parents. I didn't choose to be at the Albert Schweitzer Hospital in the 1960s in rural Haiti, where there were a lot of white doctors and a lot of Haitian people that were serving. That was where I found myself, and that was at a time when I was learning about the world around me. Of course, my cognitive development continued, but it is upon us now to deepen our insight and to reflect about where we've come from and what our experiences might have laid down as tracks in our brain. One of the places where evidence of systemic racism is, of course, most glaring is in the US criminal justice system. And I think it's really important that we talk about this in the context of understanding what's going on in our country today and where we are. This is a graph that is compiled from 2010 census data by the Prison Policy Initiative, and it's looking at disparities in prisons and jails. And you can see that while white people comprise about 64% of the US population, they're only representing 39% of the incarcerated population, whereas Black people, who comprise about 13% of the US population, represent about 40% of the incarcerated population. And this has been written about in some detail by many authors, including, I'll make you aware of this book by Michelle Alexander called The New Jim Crow. And Jim Crow laws came after the emancipation of slaves, but they were really designed to continue to take away freedoms and rights and privileges from Black people, and kept them in a very subservient situation, in a poverty trap, really, in a trap of poverty and poor health. And Michelle Alexander argues that by the mass incarceration of Black men in particular, that we fundamentally substituted one mechanism for another in terms of taking away rights and freedoms of Black men. And this itself has repercussions on Black families and on communities and on our entire society. And we can talk a little bit about some of the explicit ways in which, when a family member is incarcerated, that is a trauma for a child, and childhood trauma itself leads to downstream consequences in adulthood that are not only emotional and psychological, but are written into our very physiology and into our health. So in thinking about the path of inequity, there's so many factors, and I've bulleted them here, and I don't mean to in any way diminish the significance of these issues, but nor can I address the entire history in this presentation. So I wanted to highlight redlining, and I told you that I would do that, and we'll say a little bit more about the juvenile justice system. And I do want to comment that 75 to 93% of youth in the juvenile justice system itself have experienced a degree of trauma, physical or emotional abuse, neglect, or family dysfunction. This needs to be taken into account as we consider where we are today. We look at our patients, we think about where they came from, we look at the circumstances of their lives and wonder, how can this be, and how is this so very different from the situation in which I grew up and the situation in which I found myself. And when we study and understand and document the relationship between early traumas and subsequent impact on the brain and even our immune system responses, we get greater insight. So trauma induces powerlessness, fear, hopelessness, and a constant state of alert, as well as feelings of shame, guilt, rage, isolation, and disconnection. Of course, this applies to anyone of any race, right? Not just people of color or marginalized people. It can happen to any of us. So we should start thinking as clinicians about not asking, why is this patient or why is this colleague like this, challenging me in this way or not complying with what I'm trying to do. We should instead ask what may have happened. What are the antecedents that have led to this situation where this patient or this colleague finds themselves? And so we have to develop our capacity to imagine the experience of the other, which brings me back to the original vision of what our Center for Medical Humanities and Ethics is really meant to be all about. I told you that I would talk about redlining. I have to really thank Dr. Ferrer for sharing this image with me. I think it's been shared in a viral fashion with many of us educators. This is the San Antonio residential security map from 1935, originating from the archives at UTSA. And you see our city mapped out and color-coded, and what this reflects is a designation of areas and neighborhoods that were considered to be poor risk versus good risk, and in between, for people paying back their mortgages. So in the 1930s, the government had an initiative to try to prevent people from losing their homes in times of great economic distress. So there was this federally backed homeowners loan corporation, which would make loans to homeowners, but that excluded people who lived in highlighted in red areas because those were considered to be high risk. And the fact of the matter is that across the nation, not just in San Antonio, those redlined areas were predominantly communities of color, and the risk assessment was clearly racist in nature as opposed to a sophisticated financial and risk analysis. Now, what I'd like you to do is take, if you haven't already emblazoned this in your brain by seeing it a million times, just remember this color pattern you're looking at right now as I flip to my next slide. And this is looking at San Antonio in 2016, looking at diabetes. And notice that the darker areas are areas of higher prevalence, and those are in fact predominantly the east and west side and south parts of San Antonio. So something that happened in 1935 resulted in groups of people being able to retain their home and their family wealth and pass it down. The access to these loans greatly affected the quality of the neighborhoods, the quality of the schools, the ability for people in these areas to achieve professional and financial success or not. And this then gets written into the health of San Antonians many years later in 2016. And so the series of maps that I'm showing, of course, are a bit impersonal. But I liked this photograph from the San Antonio Express News, just reminding us that just looking at a dark color on a map and saying that's where the diabetes is makes us forget who are the human beings and in what way are they deeply affected. And so here's a gentleman who has lost a limb because he's been suffering from diabetes. And this, in fact, the diabetic amputation rate, which was the graph that accompanied the photograph in the Express News article, this image shows us that Bexar County is higher than Texas as a whole and shows us a little bit of the remembrance, the reminiscence of the color-coded redlining map that we looked at earlier. But these are really extraordinary numbers. And I've been inspired personally by someone who's, I think, making a difference in our community, Dr. Lisa Ochoa, who's a vascular surgeon. You may have heard her name and be familiar with it just because she's been on Texas Public Radio and promoting the San Antonio Vascular and Endovascular Clinic. But I've had a lot of conversations with Lisa Ochoa. And as a young vascular surgeon, she has intentionally tried to start up clinics in places where people lack access to health care. And so this is showing the map of San Antonio, of Bexar County, with color codings related now to diabetes amputations, with the darker color being areas of highest risk for amputations. And those are the places where she is intentionally placing clinics and not just setting up shop and thinking if you build it, they will come, but also trying to engage proactively with the community. And upstream of the need to amputate a limb. And this sort of intentional placing of services in underserved areas is, I think, one of the tools that we have at our disposal to try to repair many of the health disparities that we see. So here's one of Wari Allison's slides that I borrowed addressing health inequities and infectious disease now, because we are infectious disease doctors, Wari and I, and we are in the middle of a pandemic. It has been correctly stated that poverty contributes to conditions that cause infectious disease and also prevent access to healthcare. One paper describes infectious disease as a proxy for poverty and disadvantage, with subsequent risk factors affecting populations with low visibility and little political voice, imposing both a heavy health and economic burden, and having a greater impact where health systems are weak. I'm constantly learning. Just today, I had a patient family teach me something. I have a patient who's homebound due to having had a prosthetic hip removed. She's completely immobile. We were worried about her recent fevers possibly being an indication for COVID. She can't go get a COVID test. But my patients taught me Metro Health has supplied a potential solution for people that are very disadvantaged and can't get an ambulance to go get a COVID test. And we have a phone number at Metro Health that you can call, and people can get a call and say, I'm homebound, I can't get out, I can't go get my COVID test, and the COVID testing will come to you. This is an earlier slide of, I don't forget exactly which date, of COVID-19 surveillance in Bexar County with darker areas representing higher areas of prevalence. That map has been changing because I think what we've seen is COVID sweeping through the more disadvantaged areas. And then as testing moves elsewhere or as people develop seroprevalence, surviving it, then we start to see, more like green areas earlier. So this is going to be ever changing. And I do think, though, it's worth, having just looked at those redlining images, looking at the areas of Bexar County with that in mind and seeing where we're seeing higher numbers. So history matters when it comes to health inequity, whether you're talking about diabetes and amputations or whether you're talking about infectious diseases in a pandemic. And there are historical forces at play that intensify health inequalities in the present. So what are the questions that we want to answer? How can we extend the benefits of public health interventions to the most vulnerable? I just gave you an example, and I learned it from my own patient, which was kind of embarrassing because it's all the work that I've been doing with Metro Health. I didn't actually know that they had a mechanism for homebound people to get a COVID test. We should deeply understand, if we're to fix things, why patients of color, communities of color, are mistrustful of care when we want to provide it. And so that, again, a history lesson here. We can't unpack all of the 400 years of history, but we can acknowledge here at this time in this place that these differential health outcomes between Blacks and whites, and also I would add whites and Hispanics, have existed in America for hundreds of years. And most of the health disparities, most studies of these disparities ignore the impact of the real historical past. A truly historic approach, however, helps us to see past the reasons and look at the present. So it's important to acknowledge and consider this all in overcoming the inequalities. And a historically informed analysis of racial health disparities is important. It is rooted in the infrastructure of slavery in America, which we here today are not personally responsible for having created, but we certainly have benefited from what happened there, and we therefore are implicated. Early on, there were very high rates of morbidity and mortality brought about by overwork, horrendous living conditions, sexual, physical, and psychological abuse, as well as violence and forced separation. All of these marked life changes of enslaved Black Americans. The slaves had to rely on traditional medicine brought from their homelands. There actually was plantation health care provided by slave owners to some extent, but it was financially motivated as opposed to being motivated by the intrinsic value of a human life. Loss of a slave was loss of an asset. Immediately following the Civil War, mortality and morbidity rates rose in these newly emancipated African Americans. They were no longer part of the plantation health system, such as it was. And scarcity, starvation, lack of work, inability, and unwillingness of an underdeveloped and racist Southern public health system didn't take up the slack that was left behind by losing that plantation health care. And subsequently, many expert opinions have incorrectly located the cause of these disparities as being inherently biological. You can see it in the textbooks of medicine from decades ago, inherently biological versus due to social conditions. So as we think from systemic perspective of what we can do, we need to think about availability, affordability, accommodation, and acceptability. This is your vocabulary, I know, but it is important and necessary to reiterate that the affordability of healthcare is linked to the availability of health insurance. Health insurance is linked to employment. Employment linked to education, location. Did you come from a red line district? Incarceration. And eligibility for assistance for health is linked to poverty level, being poor but not poor enough for certain services, which we certainly see in states that did not expand Medicaid. So With all of this history, medical mistrust within communities of color is valid. That question is easily answered, and there are so many other examples for those who are interested in history and want to learn more, like the story of Dr. Sims, the so-called grandfather of gynecology, who actually operated on an enslaved Black woman with obstructed labor without anesthesia. And then there was Tuskegee. And yes, I know you know the story of Tuskegee, but let's highlight a few points as we reflect back on it. This went on from 1932 to 1972 at the behest and driven by the U.S. Public Health Service, studying syphilis in Black men in Macon County, Alabama. The great irony, and this was something that was illuminating for me as I went back to review all of this in preparation for this presentation, what the natural history of syphilis was well known. It was well known. And this is a paper published looking at the Oslo study of the natural history of untreated syphilis from 1890 to 1910, over 2,000 subjects. So it was well known when Tuskegee started, and before the Tuskegee study started, ostensibly to study natural history, it was already well known that these high rates of neurosyphilis, cardiovascular complications, latent syphilis, death due to syphilis, happened, and you can see the rates there. I think people do forget that the Oslo study had already shown all of the things that then the Tuskegee study said it needed to look at, because these were people who were Black. 399 men with latent syphilis and 200 men without syphilis were initially enrolled. The men who had syphilis were never informed of their diagnosis, despite the risk of infecting others, and the fact that the disease could lead to blindness and deafness, mental illness, collapse of the central nervous system, and death. They were told that the study was going to last 6 months, but it lasted 40 years for no really good scientific reason. After funding for treatment was lost, I should say, the study was continued without informing men that they would never be treated, and none of them ever got penicillin, despite the fact that by 1947, the antibiotic had become the standard treatment. Many unnecessary procedures were performed, like this man who's getting a lumbar puncture, and treatment was not only withheld, the doctors in the community where the study was going on were actively discouraged from diagnosing and treating syphilis because they were told it would interfere with an important study. And it went on until 1972. And here's the whistleblower, Peter Buxton, the whistleblower. So here's an example of somebody who is taking action and being an upstander. But he had to blow the whistle multiple times before people paid any attention. And it was finally a leak to the press in November of 1972, which resulted in public knowledge and ultimate shutdown of the study. All of the victims of the study were African American, including numerous men who died of syphilis. There were 40 spouses who contracted the disease and 19 children born of congenital syphilis. And that was 1972. It was 25 years after that there was finally an apology by President Bill Clinton offered to the 8 survivors. And here is Mr. Shaw, one of the last survivors, graciously accepting the acknowledgement by President Clinton that the Tuskegee study had been deeply, profoundly, and morally wrong. 25 years later. I mentioned the Immortal Life of Henrietta Lacks. We had the author, Rebecca Skloot, here on our campus shortly after her book was published and before she became so famous that we couldn't catch her. She did present at our Frank Bryant Memorial Lecture in Medical Ethics. And I would really urge anyone who is part of this discussion today, if you haven't read The Immortal Life of Henrietta Lacks by Rebecca Skloot, please go get a copy. It is worth your time. It is very engaging. But Henrietta Lacks is the person for whom the HeLa cell line is named. Those are her cells that were taken from her cervical cancer biopsy from Johns Hopkins without her knowledge and consent. And of course, being the first propagated human cell line, these cells have led to untold developments in biomedical research and have been at the root of probably billions of dollars worth of pharmaceuticals and medical advancements with no credit given and no acknowledgement to the family and the descendants of Henrietta Lacks. Rebecca Skloot is trying to help repair that situation. So we need to look through historically informed lenses. I think I've made that case pretty strongly, and we need to move towards solutions, not just look at the past. This chart was taken from the CDC's website today, and it's looking at disparities in cases, hospitalizations, and death due to coronavirus, looking at how compared to white population, Native Americans have about 1.8-fold higher number of cases, Black or African American non-Hispanic persons 1.4 times, hospitalizations, especially in the Native American and Black populations, close to 4 times that of white, and death close to 3 times that of the white population. So infectious diseases, again, disproportionately affect marginalized and vulnerable populations, even after the lessons that we've learned. So we really do have to think strategically about how we can get involved in health advocacy and come out from our exam rooms and think of ourselves as doing more than writing prescriptions and making referrals. And our role is important in joining with the voices of our patients and patient advocates to make a difference. The editor-in-chief of The Lancet has said, doctors can't assume that they have either the trust of the public or the support of governments unless they're willing to take part in the public debate about what kind of society they want for the sick and impoverished. And more doctors, irrespective of their specialty, responsibility, or seniority, need to enter the public arena of dispute. So apologies for showing a picture of myself, but I do think that if we're out trying to encourage one another to take action, we should walk the walk and not just talk the talk. And in my case, I've tried to engage my own family in certain aspects of advocacy. So here's some of the questions that y'all asked me. These were challenging. One of my colleagues said, this is like if you gave an introductory epidemiology talk and then people asked you to comment on smoking, neonatal sepsis, and chikungunya virus. But so the first question was, what should be the role of professional societies? In our case, what about the Bexar County Medical Society in addressing racism and discrimination? And so it's worth noting that just last month, the American Medical Association adopted a new policy officially saying racism is a threat to public health. It took a long time, but it's said by the AMA. And other organizations like your own American Academy of Family Physicians, the AAMC, have similar declarations and call to actions now. So this is a good first step, that our professional societies do speak up. And then don't forget that Dr. Patrice Harris became the first African-American woman to lead the AMA in 2019. So things are happening. What about locally? And I think with all due credit to Dr. Chiquita Collins, our Associate Vice President for Inclusive Excellence and Health Equity, points out, well, who's on the board? Who is in leadership there? Because representation matters. And are there voting members who are voicing and making urgent the need for action? And if they're not, why not? And so I will tell you that I am sometimes on the roster of the Bexar County Medical Society, and sometimes I might have forgotten to pay my dues, but I haven't particularly taken a big stand within that organization to address this issue. So that is an eye-opener. And we can all think about which professional organizations we're part of and what we can do within them. My other affiliation, or my big one for this year, is with the American College of Physicians Texas chapter. I'm currently serving as the president of the Texas ACP. So I take this question, personally now for me in my role with ACP, to think about what are we doing to address racism and discrimination within that. And this is a really good question, obviously, an insightful one, and an area for research. And that is, how do we ensure that big data and the way that we use big data in generating algorithms for decision making in healthcare, how can we ensure that this decreases rather than increases the disparities that we have in healthcare? And there have been a number of reports highlighted in our journals and our peer review literature, as well as in the press, just within the last year. And so here's an example of an article in Nature, which I've put the link there, and I commend it to you. It's a nice overview summary. The title of the article is "Millions of Black People Affected by Racial Bias in Healthcare Algorithms." And so in this particular instance, it came to light that an algorithm that was assigning people in a healthcare system to risk categories, which would then get them certain increased interventions depending on how high risk they were, this algorithm was biased. And what happened is it assumed that lower annual healthcare cost for a group of people equated to lower healthcare risk, right? Oh, these people here are not costing that much, so they are not as high risk as these other. And in fact, the Black population within this study population was had an $1,800 per year lower cost on average than white people. But this wasn't due to them not needing that amount of healthcare. It was because they weren't getting it. So it was lack of access. And so this kind of decision making for a huge algorithm then created an enormous bias that affected people's healthcare. This paper, opinion paper, which is a quick read, goes on to suggest more diversity in algorithm designers, right? Who is at the table making the algorithm and auditing the health algorithms for bias, both before and during use. So these are fairly common sense, but they need to be implemented, these kinds of solutions. So there's another article that I would commend to you for concern on big data and bias recently, and this looks at Black populations disproportionately not receiving benefits that were being allocated by the government for hospital aid, again, looking at cost and finances and resulting in really discriminatory allocation of funds. And so from the humanities world, I and my colleagues would add that it's important that we know that the kinds of questions we ask, the terms we set, are going to define the answers that we get. It's another way of saying garbage in, garbage out, but it's a nicer way of saying it, that we have to really be mindful. And bias in our questions or the terms are going to be reproduced in our data. And we should all approach our data analysis not with the assumption that it is objective, but with the assumption that because it's a human product at its origin, it is already hampered by bias, and that bias must be actively sought out and amended. So would the person who submitted the question feel comfortable piping up or adding to my comments? Because I know that I have something to learn from this incredible group here. I'm going to give a moment for somebody to unmute if they wish to say something. I see Inez is unmuted.
I was actually going to say I don't think I see the faculty member on today.
Okay. Well, very good. These are important areas. Artificial intelligence is a really powerful tool. We are clearly going to use it. It's going to make us better, but we have to be insightful about the embedded flaws. Another question that I got from family medicine was, what strategies can we employ to reduce implicit bias, either as individuals or as teams of people taking care of patients? And Dr. Chiquita Collins shared her 3 strategies from an institutional perspective that relate to training, policy, and reporting. So there's anti-bias microaggression upstander training that's gone on. I know at the center we had to nominate a member from our Center for Humanities and Ethics to be the champion. Melanie Stone had that training, and now she's to do a workshop with the rest of us to share what she learned, and that's being done department by department. Anti-bias and anti-discrimination policy is, of course, something that is being worked on at the administrative level. I serve on the Faculty Executive Committee of the Long School of Medicine, and I see opportunities for us to improve the way we go about appointing people on committees, and who is on the promotions and tenure committee, who is on the admissions committee. There are definitely opportunities for policy modifications that can help us up our game in this regard. And then what I don't know much about, and you'll have to go to Dr. Collins for this, is what is the bias reporting system that is being worked on and is tentatively set to launch early in 2021. Perhaps there are people in this group who know about that, but I was pleased to know that this is something that's being thought about. And then Rachel Pearson, my colleague in Humanism and Medicine, would say, and wrote a very nice essay in Scientific American about 5 years ago, that everybody just needs to slow down and listen, especially when they feel uncomfortable, rather than speeding up and talking really fast. It's not easy. We should practice and cultivate a game willingness to dwell in spaces of discomfort. And of course, you know this, we need to work on our pipeline, way upstream of the pre-meds, and what are the things we can do in our own community to help with the pipeline in high schools, the pipeline in elementary schools, for bringing people into the medical profession. And finally, fair promotions for faculty of color. So those are some answers to that question, and we could probably talk about a lot more. Another question was, how should we get patient feedback regarding perceived racism in primary care settings? And Dr. Romas quickly said, we already have an avenue for this using Press-Ganey survey, which all patients get. So I'm going to ask you, how many of our primary care patients in the outpatient setting get the Press-Ganey? And how does the provider get that feedback? What's your experience in family medicine? Because I don't get any feedback in infectious disease clinic.
So Ruth, I'll speak to that as a residency director. We don't get, it's been very hard for us to get specific feedback from patients about specific providers, both faculty and residents. And that's unfortunate, because it's actually very helpful for the trainees as well as for those of us trying to improve our practice as long-standing physicians.
Thank you. Dr. Lawler, did you have a comment too?
Yes, I'm a patient in the university healthcare system, and I don't recall ever getting a Press-Ganey survey as a patient. As a provider, I was totally unaware of the Press-Ganey survey. So although Dr. Romas thinks this avenue is open and available, I'm not so sure it is available. I'm not aware of it as the provider or as a patient.
Thank you. I get calls after I've had to have a couple of brushes with the healthcare system this year, and I've gotten calls, but they didn't announce and they asked me to fill out a survey or do it verbally. It came to me at a very inconvenient time, and it wasn't called Press-Ganey. And so it was hard for me to really be incentivized to answer it. But I'm wondering if that was Press-Ganey. Did someone else have a comment?
Yes. Can you hear me?
Yes, I can hear you. That sounds like Dr. Hayen. There you are. Hi, Dr. Hayen.
Hi. So I think that Dr. Romas may be referring to the UT Health Physicians clinics rather than UHS clinics. And I think that there, the response is much more systematic. And we at least get reports in that. My concern with Press-Ganey is that it's not designed to identify racism or mistreatment. It's designed to improve systems, but it's not really encouraging to have that conversation or even to bring that up in the context of the survey. So I think it's a false comfort to feel like just because you're getting a patient survey, you're going to be able to unmask that what happens.
And so thank you for those points. What would be an alternative, or what would be an initiative that could address this?
I think we need to be more intentional in terms of acknowledging our the legacy of systemic racism that you have articulated, and perhaps come to a point where you say, we recognize that there are issues here that we may not be aware of, and we want you to let us know if this is happening in this context. So in some ways, it's giving permission to the person who experiences the injury to articulate that without fear that you're going to be kicked out of the clinic or lose your access that you have so hard worked to gain.
And would the mechanism be a focus group or an anonymous, a separate anonymous survey? Or other?
I don't have the answer. I don't pretend to have the answers, but I think that it could be the same survey, but also needs to be a communication campaign from our clinics to say, we acknowledge that this is a reality. We need to do something about it.
Well, I imagine you would find a lot of interested medical students if there were a project there to get launched. And sometimes our community service learning projects that we initiate from within the center go on and become more significant and more helpful. So I think this is also something that I can bring back to the Long School of Medicine Faculty Executive Committee and see what kind of dialogue we can get about it. So,
I have a question related to your earlier slide. What is gain willingness?
Oh, it's just an adjective, like just goodwill, meaning say a goodwill kind of willingness. Yeah, I'm game. I'm game to do that.
Okay, thank you.
And I'm sorry if I stumbled when I read it. How to begin the conversation when addressing racist behavior in patients or clinical team members. So that is one of the areas that is specifically being addressed by this initiative Dr. Collins has set in motion for the upstander training. And the training is supposed to get to every department for the whole School of Medicine. And our dean, of course, hopes that 100% of all departments will attend it. And I would ask if anybody wants to share, who was your department champion for the upstander training, and have you all started providing this for your group? We haven't had ours yet in the Center for Medical Humanities and Ethics, but I know who's supposed to do it, and that's Melanie Stone. I guess we'll leave it there. Inez, can you just tell me where we are at with time? I turned my phone completely off so it wouldn't interrupt me, and I can't see a time.
You have about 7 minutes till about 1.
Okay. All right, so we'll just walk through some of these really quickly to make sure that there's a few minutes left for questions, and if people want to put something in the chat, I'll try to take a look at that as well. Personally, I think it's really important that we start on an individual level with talking to our patients and advocating for individuals. This is an unflattering picture of me. This is the day we got evacuated from New Orleans out of Hurricane Katrina and Charity Hospital. I'm there with my staff from the 9th floor and passionately advocating for each of my fellow healthcare providers to get someplace safe and dry. And these are sometimes we can't anticipate what circumstances we're going to find ourselves in, but when we recognize that we have an opportunity to advocate for someone, that's a way that we can manifest our intention to repair these inequities. We need to acknowledge healthcare is broken. How do we fix it? And becoming knowledgeable includes proactively taking advantage of a lot of the educational resources that we provide for each other, like the Frank Bryant lecture that we do here at the Center for Medical Humanities and Ethics every year. Becoming involved in advocacy, and it takes many forms and people will have a different comfort level with what their advocacy looks like depending on what they're good at. But serving the underserved is a really good way to take this up. And I'm not going to go through the next 6 slides in detail because I don't think it's as valuable as the opportunity to talk to each other, but I want to make you aware that I found what I thought was a helpful worksheet on steps to speak up in our own environment, and I've put the website there. And I'm going to flip through them just rather quickly. You know, rather than calling other people names, point out the behavior by repeating, you know, what the person said, and then saying, is that what I hear you saying? And certainly we want to avoid, when we speak up, we want to avoid labeling or name calling. We want to appeal to people's better instincts. We can set limits in our work areas. And we can find a way to be an ally. I will say, I do want to say this, my borrowing of Wari Allison's historical slides for this presentation was my effort to be an ally for her work. We have to be vigilant, don't risk silence, realize that change happens slowly, be self-critical, change our own behaviors, share our experiences. I have some experiences that I can share, but I'm more interested in hearing yours. And then finally, here's some thoughts from a health affairs article that just came out in September, proposing that institutions must be intentional in reducing disparities. I believe that our institution is taking some really good steps in that direction, as I've outlined. Pay for performance models should include benchmarks for health equity, measures of what the hospital is doing proactively to reduce health disparities, or adopt disparities impact assessments, maybe things that aren't being addressed by the press Gainey surveys. And then investing in programs that prevent or improve chronic conditions before hospitalization. I am a huge fan and would love to know more about the work of this department, Family and Community Medicine, with community health workers. I am personally of the opinion that we need to have more of healthcare and preventive healthcare taking place in the neighborhoods where people live, with people who represent that neighborhood, and with more focus on that, on those upstream locales. We will have a less costly system and remediate some of the great disparities. And then this is really my last slide, after which I want to talk to you. This is from Rachel Pearson's essay in Scientific American. I liked how she ended it, saying, ultimately, I hope that revising our understanding of objectivity in medicine can do more than just address bias. Medicine could be, and it should be, a tool for ensuring that all people's lives are cherished. If we doctors begin to earn our authority as science-using moral leaders, then both medicine and society have much to gain. And there's the link to Rachel's essay. And then I like this quote, which is from Jason Rosenfeld, who leads our global health program, and it illustrates why I believe that our global health education program is contributing to this effort. Mark Twain said, travel is fatal to prejudice, bigotry, and narrow-mindedness, and many of our people need it sorely on these accounts. Broad, wholesome, charitable views of men and things cannot be acquired by vegetating in one little corner of the earth all one's lifetime. Well, there's an endorsement for the COVID vaccine so we can get out of our corners, but I do believe that we cannot truly imagine the experience of the other, with a capital O, if we don't take proactive steps to burst the bubble that is between us. So with that, I'm going to end and invite anybody who's still with me to interact with me in the chat or unmute yourself.
In the absence of any questions, I will take Dr. Berggren. Thank you so much for your time today. We appreciate you being here, being able to give us this presentation. I will definitely make sure if there are any follow-up questions to send your way. We'll put them in an email so that way you can be aware of them. But thank you to everyone.
All right, and thank you for your attention.
Have a good day.